This presentation will introduce you to the SOClear lens and how to fit it. The SOClear lens is defined as a corneoscleral lens. This means it rests some of its weight on the cornea and some on the sclera, unlike a true scleral which rests all of its weight on the sclera. It is essentially a large diameter RGP lens available in diameters from 13.3 to 15.5 millimeters. What makes the SOClear unique is its patented relationship between base curve and scleral curve. You may wonder why we would choose to give someone such a large lens. Well, the reason is that these larger lenses are very, very comfortable. And because they are rigid lenses, they create corneal astigmatism by making a spherical tear lens. Their large size also means that there's less chance of getting dust under the lens. And because their size makes them very stable, the multifocal version works very well. SOClear is made from plasma-coated high decay materials, giving it excellent wetting properties and making it a good choice for dry eyes. Potential patients would be all those you would like to fit with a conventional RGP, those with high corneal astigmatism, those wanting crisp vision, those who can't wear their corneal lenses anymore, presbyopes, especially those with astigmatism, patients with dry eyes, those who can't wear soft lenses, those who work in dusty environments, and those with irregular corneas. This is a very useful lens for those with keratoconus, especially early keratoconics where you can offer them a comfortable lens straight away. It's also useful for those who are intolerant to conventional RGPs or where scarring is an issue. It can also be used when refitting from soft perms, and it's very useful for vaulting intacts. Because SOClear lenses are much larger in diameter than corneal lenses, they are fit a little bit more like scleral lenses. The central base curve becomes less important. Instead, the sagittal depth becomes far more relevant. The sagittal depth is the depth of the eye at the diameter of the lens. Essentially, SOClear lenses are a set of lenses with different sagittal depths. The lens has 4 curves, with the outer 3 curves setting the depth of the lens, whilst the central base curve has a limited effect on the fit. Its only function is to alter the clearance at the limbal area. The standard fitting set contains 18 lenses. They are labelled with base curves from 7.11 to 8.65 in 050 diopter steps. As they are a US design, the fitting steps are in diopters, which accounts for the unusual fitting steps in millimeters. So if the SOClear lens is basically a set of lenses with different sags, how come each lens is marked with a base curve? This is because the sag of the SOClear lens is designed to match the sag of the average eye with that central base curve. In general, steeper base curve eyes have higher sags and vice versa. Here we see the steepest lens in the set, and you can see that it has a far greater sagittal depth than the flattest curve lens. But the actual sagittal depth of the eye depends not only on the corneal curvature, but also on the corneal diameter. So in general, patients with larger than average corneal diameter will have higher than average sags, and those with smaller corneal diameters will have less sag than average. Once the peripheral curves have been decided on, the sag of the lens is set. Now if you alter the central curve independently, all it does is alter the limbal clearance. A little bit counterintuitively, if you flatten the central curve, the limbal clearance increases, and if you steepen the central curve, the limbal clearance decreases. The key features of a successful SOClear fit are that the sag of the lens matches the sag of the cornea, the scleral curves align with the scleral conjunctiva, the mid-periphery of the lens vaults the limbus, allowing tear exchange. So the first thing to do is to determine the lens which aligns with the sclera and has the optimal sag for the cornea. Then we do our overfraction to work out the power of the lens, and the last thing we need to do is ensure that we have the correct limbal clearance, and then we can order our lens. To pick our first lens, the first thing we do is determine mean K. If the cornea is of average diameter, we select the lens closest to mean K. If the cornea is larger than 12 millimeters, we select a lens 1 diopter or 2 fitting steps steeper, as we expect to need a higher sag. However, if the cornea is smaller than 11.5 millimeters in diameter, then we select a lens 1 diopter or 2 fitting steps flatter than the mean K, because we expect a lower sag. For normal corneas, you can insert the lens directly onto the cornea like a soft lens with a few drops of saline in it. But for keratoconus, you will need to fill the lens with saline and have the patient's head facing the floor whilst you bring the lens up from below. In this case, it's often useful to use a plunger to stabilize the lens. The lens is assessed with fluorescein. In a flat fit, the lens does not have enough sag to fit the cornea. As you can see from the diagram, this will lead to standoff at the edge of the lens and central corneal compression. Because of the edge standoff, the lens may feel edgy. A steeper lens should be used to increase the sag. Here is a video of a flat fit. You can see the lens almost hanging off at the edge. If we indent the sclera just below the lens flares away very easily. This lens is quite uncomfortable. If the lens is too steep, in other words it has too great a sag, then bubbles may develop centrally and there will be impingement of the lens on the sclera. If you see vessel blanching, such as the picture on the left, or significant central clearance as in the centre, or a large bubble under the lens, as on the right, then you probably have a steep fit. If in doubt, go flatter until you are sure. This is a video of a steep fit. In the video you can see significant central clearance and also scleral impingement. This lens will become uncomfortable after a while. If we indent the sclera just below the lens, we see that it's quite difficult to get the lens to flare away from the eye. Here is the ideal fit. The sag of the lens matches that of the cornea, the periphery is aligned with the sclera, and there is a band of clearance at the limbus. This lens will be incredibly comfortable, comparable if not better than a soft lens. If we look at the video of the ideal fit, we see the same. Good alignment with the sclera, and the lens has the optimal sag for the eye. We now have the lens with the correct sag, and with this lens in place we do our over-refraction. All the diagnostic lenses are -3 diopters in power. Now we move on to our final tweaking of the lens. We want to ensure a good band of mid-peripheral clearance to allow good tear exchange. If there is insufficient clearance at the limbal zone, this may cause adherence, staining, poor comfort and lack of tear exchange, which could even lead to edema. To increase the limbal clearance, we need to flatten the central curve while keeping the peripheral curves the same. Here you can see what happens to the limbal clearance if the central curve is flattened by first half a diopter and then 1 diopter. The limbal clearance increases. On the other hand, excessive clearance may lead to central staining and bubble formation at the limbus. To decrease the limbal clearance, we need to steepen the central curve whilst keeping the peripheral curves the same. This is what we're aiming for, a good band of clearance, but just not too much. We are going to modify our central curve empirically, usually by 2 fitting steps. So to add limbal clearance, we order the lens 2 steps flatter in the centre, and we add plus to correct for changes in the tear lens. For less limbal clearance, we order the lens 2 steps steeper in the centre and we add minus to correct for changes in the tear lens. 2 fitting steps should produce a significant change. This makes the power of our final lens the power of the trial lens plus the over-refraction plus any changes to our tear lens from modifying the central curve. There are a couple more considerations to make. The first is the total diameter of the lens. This needs to be 1 to 1.25 millimeters beyond HVID. The diagnostic lenses are all 14 millimeters, so use this as your guide. However, altering the diameter of the lens alters the sag of the lens to a certain extent. So if you're going to make very large increases, then you may want to order a lower sag lens and vice versa. The last thing to consider is whether or not you want to have a fenestration on the lens. A fenestration allows easier removal of the lens, but it can allow the lens to settle back onto the eye. If bubbles form after the lens has been inserted, or if the lens settles on after the tolerance test, then order without the fenestration. So we have come to the point of ordering our lens. The order should contain the base curve of the lens that gave the correct peripheral fit and sag, any adjustments made to the central curve, the power of the lens required, the overall diameter, the material and tint, and if ordering a multifocal, the ad and the segment size. A fenestration comes as standard unless you ask for it to be omitted. For example, let's say that our ideal sag lens is a 758 lens. However, there is inadequate limbal clearance, so we've decided to flatten the central curve by 2 steps. The over-refraction is minus 250. We are happy with the diameter, but after our tolerance test, the lens has settled on, so we've decided not to have a fenestration. So we order the 758 lens with a 776 centre. The power of the lens is minus 3, which is the power of the diagnostic lens, minus 250, which is the over-refraction, but we need to add plus 1 as we flattened the centre of the lens by 2 fitting steps. Hence our lens is minus 450 diopters. We will order the high DK Boston XO material, blue handling tint with no fenestration, and a diameter of 40. To remove the SOClear lens, there are 3 methods. The first is the tiddlywinks method, which is where we use the lids to break the surface tension of the lens on the eye and flip it out. The second is the finger touch method. In this method, touch a dry finger against the lens and ask the patient to look swiftly to one side, and the lens will literally fall out. You can also use a suction cup, but use it at the edge of the lens to break the surface tension. If not, the lens will remain sealed on the eye. The standard fitting set will also fit around 70% of keratoconics, but there is also a set for more advanced keratoconus, and you can also get this lens in reverse curve form for post-surgery. And don't forget there's a multifocal. The lens itself should be inserted with saline, but lens care should be with a soft lens solution such as Synergy or Regard. This is because RGP solutions are too viscous. The lens should be cleaned with an alcohol cleaner every day, which will remove lipids and proteins. The lens should last at least 6 to 9 months. Okay, let's test and see what you've learnt. What do you think about this lens? Have a look at the edge of the lens. There's edge standoff causing discomfort. Let's steepen this lens. Take a look at the limbal clearance of this lens. Is it too much or too little? It's too little. What will we do with the central curve? We'll flatten it and adjust the power accordingly. Take a look at the edge of this lens. What's happening to the vessels? Here we have a steep edge causing vessel blanching. We need to flatten our lens. Take a look at the limbal clearance of this lens. Is it too much or too little? It's too much. What should we do with the central curve? We should steepen the central curve and adjust the power. Take a look at the central clearance of this lens. Is it too much or too little? It's too much. This lens is too deep. We need to flatten the lens to reduce the sag. Take a look at the central clearance of this lens. Is it too little or too much? It's too little. This lens is too shallow. You can see the central compression. We need to steepen the lens to increase the sag.